This is Emily Peters recording for Advanced Concepts of OB-Peds unit, the cardiovascular unit, chapter 19 in the separated book, but chapter 41 in the combined text. Alright, so this is a diagram that can also be found in your book, there's a very similar one in your book. That shows on the right side or the left side at figure A that fetal circulation. That fetal circulation enters from that umbilical vein, which is down there by that ductus venosus, and goes to the liver, and then into the inferior vena cava, which is where that ductus venosus is at. And then it goes up and into the circulation. As you note from the picture, that it is mixed blood flow. Oops, sorry about that. Mixed blood flow. Then when we switch over to figure B, that is what the circulation becomes after that baby is born. When that newborn takes that first breath, this is when we start seeing those changes to go from fetal circulation to normal circulation. So those lungs begin to inflate, and then that reduces pulmonary vascular resistance, and that changes that pulmonary artery pressure. Okay, pressure in the right atrium decreases as well, and then blood flow to the left side of the heart increases, and the pressure in the left atrium increases. Because of this pressure, this changes that foramen ovale that allows for the opening between the right atrium and the pulmonary vein. And then that ductus arteriosus also closes up there in that aorta, and which allowed for an opening between the pulmonary artery and the descending aorta. So that closes off and it becomes a ligament. So if there are issues with this circulation changing, it typically occurs with that ductus arteriosus or patent ductus arteriosus or that foramen ovale. And there's different things that we can do as healthcare providers with doctor's orders, of course, that can help us close those, so that'll allow for that good circulation that you and I have. And that allows us to have the non-oxygenated blood versus the oxygenated blood. And as you can see, our arrows indicate that direction of blood through. So make sure if you are not familiar with the normal blood flow, that you go over that. Hopefully you've learned that not only in pathophys, but I believe you covered some cardiac issues before. This is something you are going to need to know again in concepts of nursing. And in concepts of nursing, they're also probably going to make sure you know the different valves and things as well. Okay, so this slide is just kind of giving you some review on some other things, but besides congenital anomalies, cardiac anomalies are a major cause of death during that first year of life. We don't always know what causes these cardiovascular anomalies to occur. We know 8% of them have a genetic cause. So like kids that have Down syndrome, because of the genetics with that, it can lead to cardiac issues. There are some maternal factors that also increases this risk for children to have cardiac heart or congenital heart defects. Moms that are diabetic, moms that have had rubella or are exposed to rubella during pregnancy, those moms that drink a lot of alcohol, moms with lupus or other misconnective tissue disorders, PKU, poor nutrition, and even like anti-epileptic medication use of that mother. There is even some other medications, I believe. Some of our depression medications as well have been shown to cause some cardiac defects in our children. Okay. So, breaking down congenital heart disease versus acquired heart disease. Hopefully you guys know this, but just in case. Congenital heart defects are structural anomalies that are present at birth. Okay. About 8 in 1,000 live births have some sort of CHD or congenital heart disease. These are those chromosomal defects. Okay, so Down syndrome, Turner syndrome, trisomy 13, trisomy 18, Williams syndrome, Prader-Willi syndrome, Cry-du-Chat syndrome. You may have heard of a few of these. Okay, about a third of the infants with a congenital heart disease will have a disease serious enough to result in death or require some sort of major intervention, such as a cardiac cath or a cardiac surgery during that first year of life. So, what are some complications of these children having a congenital heart disease? Heart failure, hypoxemia. These kids can have growth retardation, developmental delays, and pulmonary vascular disease. And many of these kids will also have failure to thrive. Acquired heart disease. So these are things that are a result of an underlying cardiovascular problem. Okay? That there are things that occur after birth. So like heart failure. So rheumatic fever. We learned about rheumatic fever and growing family. If you do not know what rheumatic fever is, I would have you go ahead and research that yourself. Rheumatic fever, as we know, can affect the valves of the heart, and then that can affect and lead to heart failure. Cardiomyopathy, ineffective endocarditis, hyperlipidemia, hypertension. Okay, and most of those, what do we think about hyperlipidemia and hypertension? Adult issues. Well, we're starting to see them in our young children, even our preschoolers. And Kawasaki disease. Okay, so here's some common medical treatments. Hopefully you guys know what these are and have seen these before. Oxygen. Now remember, oxygen may not always help a whole lot with some of these cardiac defects that we're going to talk about. However, it does sometimes help a little bit. Chest physiotherapy may be something that's going to help if we're having issues with secretions. Chest tubes, and this is typically used for open heart surgery, so if we have a pneumothorax or something that occurs. And then we can do pacing, like pacing wires. They're having arrhythmias, cardiomyopathy, heart block, things like that, and then we'll do pacing for our children as well. So, what do I do as a nurse? Well, we need to, when we have a child coming in that is being presented with a possible cardiac issue, or they already have a cardiac issue and they're coming in for follow-ups. So we need to do a few things. We need to find out when symptoms started and how they progressed. Any treatments and medications used at home. Along with that, don't you think it's kind of important for us also to look at why, if they're following their medical regimen, right? Are you taking your medications as prescribed? And if they're not, why they're not taking those medications, because that can give us some indicators of why their history is going the way it is. Those signs and symptoms of problems: orthopnea, dyspnea, being fatigued easily, growth delays, squatting. I will get into that later. Edema, dizziness, frequent pneumonia. Because if I'm having pneumonia, what do you think that is could be related to. Maybe some backing up of fluids into our lungs, so maybe a sign of heart failure. Kids that are having trouble with their heart may also have trouble with their breathing, and therefore they're going to be tired and they're not going to want to eat very well, so those signs of poor feeding. Got fatigue, lethargy, vomiting, failure to thrive, diaphoresis, delays in their motor development, and cyanosis and tachypnea. Now remember, with delays in their motor development, we need to find out if this is something that is new or if this is something that's been going on for a while. If this is a new thing, then and this child hasn't had any cardiac issues, then we need to start looking at some issues. Now, if this kid has had cardiac issues and we're starting to see delays, that could be an indicator of how well our treatments are going as well. Some other things to think about in the history is, especially if we don't know the kid has a cardiac issue, is to find out what happened during that birthing process and during pregnancy. Also, if that child's getting sick a lot, those chromosomal abnormalities. Was it a premature child? Premature kids sometimes have issues with the closing of those, like the ductus arteriosus or the foramen ovale, and that can give us an indicator of some things we might need to do. Autoimmune disorders, not only in the patient but in the patient's family. And use of medications. So we know corticosteroids can affect different things as well, but we also need to know what medications mom might have had. So that mom's risk factors, so mom's maternal alcoholism, that mom's with diabetes, the mutations, chromosomal, exposure to x-rays. That's why pregnant women need to be very careful when they're doing being exposed to radiation through x-rays. So girls, when you become pregnant and you're doing your nursing, make sure that you don't hold for a lot of x-rays. It's sometimes better not to hold for any. That lead may not just protect you enough. And then that rubella infection and that mom that doesn't eat well. Once again, if that mom doesn't have good nutrition, that's going to affect that child's development. Moms that are older also are increased risk for kids that will have congenital heart diseases, also other congenital issues, drugs, genetics, and those meds that mom has used during pregnancy. And as we know, some meds moms can't come off of, and there's nothing they can do about it, but that can make us more aware of what to screen our children for when they're having problems. So some other things to be aware of is that family history of issues like high cholesterol, diabetes, obesity, inactivity, stress, and high cholesterol. Because as we know, we tend to pass things on to our children, but what our lifestyle's like, our children's lifestyle could be very similar. So we need to be aware of that. We may have to do a whole family education and family changes to help our children. Okay, so some signs and symptoms these kids may present with that can give us an indicator that there could be some sort of cardiac disorder. Cyanosis, edema. The clubbing is not going to occur until that child has had a significant amount of time having low oxygenation. So kind of be aware of that. So those kids that are born with cardiac defects, we may start seeing clubbing as they're getting closer to that year age. However, we should not be seeing clubbing like day one. Fever, retractions, that shows that there's working the breathing and they're having trouble. The prominence of the precordial chest wall. If that heart is beating really fast, you can see, and really hard, you could see it on their chest wall in the movements. Visible engorged or abdominal pulsations as well. Also, signs of the precordial chest wall could be signs that that heart is enlarged. Okay, and then if we're having engorged vessels, that could be a sign of backing up of fluids and a trouble that heart beating and fluid overload. Same with abdominal distension. Okay, so this is a very busy slide. Some things that I want you to know related to murmurs. You have different locations. When we are talking about a couple of these cardiac defects, the location is going to be important to know. The grade, what I want you to know is it soft or can you hear it with the naked ear? I don't necessarily want you to know the different grades and how to tell that. That is something you will learn if you end up going into more of a cardiac type of nursing. The pitch may be important to know as well, and only to those specific disorders. And once again, you, in the pediatric world and in the adult world, you can tell difference in how that patient is sitting on, because that changes the location of where your heart is when you are listening for a murmur. So that may change a few things. Okay, so some things we do to take care of a child with a cardiac disorder. We need to help improve their oxygenation, get that good nutrition. We're going to help that family with coping, and there's a lot of different ways we'll do that. That post-operative nursing care, kind of think about some of those things that we will do, from education beforehand and things that we need to be aware of after. They've been under anesthesia, so that can affect their increased risk for pneumonia and things like that as well. So different breathing techniques, to pain control, to how to get them up and moving, games, enticing things. And we've talked about a lot of these things, so hopefully you are aware of them. And we don't need to spend tons of time discussing them, but kind of think back. Prizes, encouragement. Sometimes our problem is more along the lines of the parents because they don't want to see their child in pain. So we as nurses need to help encourage that movement. What can we do to help prevent infection? And then teach those families for the signs and symptoms of infections, because these kids could end up with scars from the surgical procedures that they've gone through, and incisions. And lots of education on what we need to do, from medications to follow up to diet and exercise. Okay, so we have 4 major categories of congenital heart diseases. Defects that cause increased pulmonary blood flow, defects that cause obstructive blood flow, defects that cause decreased blood flow, and defects that involved mixed blood flow. We are going to cover one disorder under each of these categories. And those are the 4 main disorders I want you to be aware of, but you need to know how these defects work, because it's going to be very similar for, if you were to go to boards and they're going to give you a different disorder. I can't cover everything, but if you understand how a disease that causes increased pulmonary blood flow works, you should be able to answer questions no matter what part of the defect is involved, okay? Okay, so once again, going back to that education, we should know this, but once again, that review, kind of remembering what we need to do, making sure we teach those parents to give those meds as ordered and as prescribed, weighing the child at least once a day as ordered. Sometimes it might be more frequent, sometimes it might be less frequent, but remember, what's those keys for getting that most accurate weight? Same time of the day, the same amount of clothes. So what do you think are some good recommendations so parents don't have to remember it? Like right before bedtime, after a bath, before they get in their jammies, or something like that. Or first thing in the morning after you've changed the diaper, or the child has gone to the bathroom, throw them on the scale, and then when they're naked and then put their clothes on. Something along those lines, so that you can kind of get that accuracy. Kids need to be active, but we also need to provide them with rest periods. So depending on how severe their disorder is will depend on how much rest periods and some things you need to do, but we need to remind the parents that it's very important for these kids to be active. That good, nutritious diet, and then any restrictions, fluids for foods. The younger the child, the less likely we're going to do fluid restrictions, because as we know, all infants, their only way to get nutrition is through the fluids. Salt may be altered, potassium, different things like that, depending on their meds as well. Some of the similar things we do for our adults. Remembering to teach our families those different ways to prevent infection. The following up the schedule for tests and procedures, and what can we do? We can work with those schedulers, with the families, and getting those appointments scheduled at the same time as well, same time of the day or same day of the week, things like that, so that the parents aren't having to take the child out of school or taking off a lot of time to get those kids into their appointments. Getting them involved in different community support services depending on what kind of alterations they have. So if they are starting to show some developmental delays, we can get them some extra education, extra treatments. And then those signs of issues. Okay? And I'm not going to read those off of the slide for you. Okay. So what kind of things can we do to help a child that is having perfusion issues? Whether it's increased or decreased output to changing their nutrition. We have a lot of good nursing care plans in this book. In the combined text, page 1460 through 1463. I cannot remember what it is off the top of my head in the separated text, but it's that nursing care plan. It's probably 19.1 in the separate text. An overview of the child with cardiovascular disorders. These things should be things you guys know, like using our beta blockers or using diuretics. What can we do with nutrition, vasodilators, things like that. Okay, so getting back into our different types of disorders, we have those 4 major categories, right? So they also can be broken down into 2 other categories. We have acyanotic and cyanotic. Under the acyanotic category, you have issues that increase that pulmonary blood flow, and then you can have issues that cause obstruction to the blood flow. So if you understand what causes an acyanotic issue that either increases pulmonary blood flow or decreases obstruction or causes obstruction to the blood flow, you should be able to answer questions about all of those things that are underneath of it. We are going to focus on ventral septal defect and pulmonic stenosis. Under cyanotic, disorders that causes cyanotic issues, you can have things that cause decreased pulmonary blood flow or mixed blood flow. We are going to look at tetralogy of flow and hypoplastic left heart. But once again, if you understand what causes cyanotic issues and either decreased pulmonary blood flow or mixed blood flow, when you get to boards, you should be able to answer questions about the other issues we do not discuss. Okay, so getting to that acyanotic stuff. When you have an acyanotic issue that causes increased pulmonary blood flow, you have an increase in blood in that right side of the heart, which increases the blood moving to the lungs. Okay? The effect of this increased pulmonary blood flow will depend on the volume of flow, which is dependent on the size of the defect. So if you have a very small defect, you're going to have a very small amount of that increased pulmonary blood flow. And so your symptoms may not be as severe. So excessive pulmonary blood flow can overwhelm the abilities of the lungs to move blood to the left side of the heart. So we get too much blood building up in those lungs, and it's going to make the heart's going to work harder to try to pass blood that's going into the lungs to try to pass it into the left side of the heart. But it's going to build up and saturate and sit there in the lungs, and then it's going to back up. Okay? So if you can kind of think of what's going on if I have extra fluid in my lungs, that can give you an idea of some things you're going to see in these children. We are going to look at that ventral septal defect, or VSD. 20 to 30% of all congenital heart defects are this type of acyanotic lesion. So, I have increased pulmonary blood flow to my lungs, and I have this extra blood kind of hanging out in my lungs. So what's that going to do? I'm going to have wet, boggy lungs, which then is going to cause for poor gas exchange. That child is going to become tachypnic and eventually tachycardic because they're going to breathe hard, and then their heart's going to work harder because it's going to continue to try to push that blood forward to get it where it needs to be. But I have extra fluid in my lungs, so I'm going to have rales. But I also have the lungs. They're a nice, dark place, right? And then I have all this extra fluid in there, and it's damp and wet. What do you think that causes? Pneumonia or infections. So this kid is going to be at a high risk for infections. We're also going to see those signs of heart failure, retention of sodium and fluid, because what's our body doing? We're going to increase our blood volume to compensate for that decreased amount of blood that's getting to my peripheral circulation. So my body's going to keep producing more things to get more blood, but it's just not going to go anywhere, okay? Or it's not going to go very far. This kid's going to get exhausted, so it's going to start having feeding difficulties due to the tachypnea that's going on, and they're working very hard to breathe, they're working very hard for their heart, and they're increasing the caloric expenditure. So they're not eating well, and their calories, they're spending it like crazy. So what do you think that child's going to look like? They're going to be thin and small. They're going to have feeding problems. They're going to be tachypnic. They're going to have a high heart rate, so tachycardic. And they're going to have signs of diaphoresis, fluid buildup in their eyes. Okay, so periorbital edema. You'll also see scrotal edema and labial edema in our infants. And then they're going to have frequent pneumonias and being treated frequently for pneumonia. Okay. Sorry, this slide is in the wrong spot. The tetralogy flow, ventral septal defect, pulmonic stenosis, and hypoplastic left heart are what we're talking about. Okay, so getting back to ventral septal defect, which is a increased pulmonary blood flow, right? So they had those wet, boggy lungs. So what is causing this issue? Well, with a ventral septal defect, that's the ventral, the septum between the ventricles, okay? So you have an abnormal opening between the right and left ventricle. It can be very tiny, the size of a pinhole, to a complete absence of that ventricle, or that septum between the ventricles. So your right and left atrium could be completely open to each other. The smaller the defect, the more likelihood of the chance of it closing spontaneously on its own during that first year of life. So they may not need intervention. So here's a nice picture of it. So we have that opening between the right and left ventricle. And what's it causing? So deoxygenated blood mixing with oxygenated blood. So we're going to have a little bit of deoxygenation, but everything's kind of working because you're still getting a lot of that deoxygenated blood and oxygenated blood circulating around. So your kid's going to have some cyanosis, but it's not going to be severe. So that's why it's considered an acyanotic defect, because you're getting a mix. Remember, this child is having an acyanotic defect that is causing what kind of blood flow? Increased pulmonary blood flow. Okay, so we're going to have those cyanotic, or those signs and symptoms that I discussed earlier when I broke down acyanotic with the increased pulmonary blood flow. So congestive heart failure is common because what's going on? That blood is backing up, and what happens with congestive heart failure? The fluid volume backs up. Something causes it all to back up, and then the heart begins to fail. You are going to hear a holosystolic murmur that's at the left sternal border, okay? It isn't giving you a good location for it, but you're going to hear it kind of on that left sternal border. This kid's going to also have signs of bacterial endocarditis, inflammation of the endocardium due to bacteria because of all that fluid buildup. And then they're going to have pulmonary vascular obstructive disease because what's going on? That fluid is building up in the lungs, and there's an obstruction that is not allowing fluid to completely go where it is. And that obstruction is due to that increased fluid buildup, and it's not able to work to push it everywhere. Okay. So what do I do to help this child? If that hole does not close on its own, we can do a couple different things. We can do a complete repair, which we can do with sutures, or we can do this Darcon patch. I kind of like to explain it similar to like a drywall patch. It's a mesh type patch that it goes over the hole, sewn together, and then scar tissue builds up and it closes it off. To do either the sutures or the patch, you have to do cardiopulmonary bypass. You're going to break open the chest and do a major surgery. There are non-surgical treatments doing cardiac catheterization. The last I heard it was investigational. I believe the U is starting to do this a little bit more, but they're going in and doing similar to like a stent, where a stent, pushes open a hole. This is something that they go in and they put, like, I don't know, like a balloon in there or something that closes off the hole. Okay, now on to, we're still in the acyanotic issues, but something that is causing obstruction to the blood flow from the ventricles. Okay, these obstructive defects impede the blood flow out of the ventricles. So if it's on the left side, it's going to cause some congestive heart failure. If it's on the right side of the heart, it's going to cause cyanosis. We're going to talk about pulmonic stenosis. All right, so here is a picture of pulmonic stenosis. So, normal heart, and then the issue, stenosis. It's occurring at this pulmonary valve. Okay, so you either have a narrowing of that pulmonary artery around the valve, or the valve is not working correctly and not allowing for that blood to flow through out of the right ventricle up through that pulmonary valve, and on the pulmonary artery. In severely ill patients, they will have a murmur, but it's going to be softer due to a decrease in that cardiac output and the shunting of the blood elsewhere. So the more severe the issue, the harder it's going to hear the murmur. So, signs and symptoms. You may be asymptomatic because if that narrowing isn't very big and still allowing a lot of blood flow through that valve, you're not going to have a lot of symptoms because the blood's going to be able to flow kind of naturally into the pulmonary artery and then getting into the lungs. Okay. The more severe that narrowing is and the smaller our outlet is through that pulmonary valve and into the pulmonary artery, the more severe the symptoms are going to be. Okay? So kids with severe narrowing of that valve or artery, they're going to be cyanotic because blood isn't getting to the deoxygenated blood isn't getting to the lungs, and so we're not getting that good circulation. You're going to hear a loud systolic injection murmur at the upper left sternal border. Okay, so the other one's going to kind of be mid-sternal. The pulmonic stenosis is going to be near the upper left where that pulmonic valve is at. Okay, you're going to see cardiomegaly because what's going on? That right side of the heart, the right ventricle, is going to keep working harder and harder and pumping and pumping and pumping. And what do muscles do when it works harder? They get bigger. Well, we don't want our muscles to get bigger in our heart, but because that's going to cause that muscle to weaken and the heart to weaken. But that's what's going to happen. So the heart's going to keep working and working, and so that's going to make it bigger. This kid's also going to be at risk for bacterial endocarditis because they're going to have inflammation of the endocardium, and all that fluid that's backing up and kind of hanging out in that area is going to be at increased risk for infection. And guess where the fluid is going to back up? It's going to back up into the right atrium and then back out into the body. Okay, so what do I do to help this child? We're going to do surgery or angioplasty. Okay, so prognosis is very low for either the surgical or non-surgical. We like to do the non-surgical first, right? Because our recovery rate is going to be a lot better. And then the mortality rate is going to be a little bit less. But not much. However, by doing the non-surgical treatment, we could have some long-term problems. We can have restenosis or we can have incompetence of the valve that can occur. But this could happen even if I replace things. Okay. So surgical treatment, we are going to do a transventricular valvotomy. So we're going to open the valve or remove the valve and put a new one in. That's going to cause cardiopulmonary bypass surgery because we have to cut that chest open and get in there and get into that heart. But if I do balloon angioplasty, what am I going to do? I'm going to just dilate that valve and break open any adhesions or anything that's occurring and allowing for that blood flow to go a lot easier. And hopefully less side effects, right? Because the recovery time is going to be a lot quicker. This is our treatment of choice, especially for our neonates and even some of our older kids, because less likely for long-term effects or complications anyways right away. Okay, so cyanotic lesions. Now we're going to be thinking about, okay, these kids are going to have cyanosis a lot. And then, but we have two different forms, right? We have cyanotic lesions that cause decreased pulmonary blood flow or mixed blood flow. We're going to start with decreased pulmonary blood flow. We're going to talk about tetralogy of flow. This is when you have an obstruction to the blood flow to the lungs, or you have embryonic failures that result in no connection of right-sided blood flow to the lungs. Okay? Because little to no blood reaches the lungs, there is less to or no blood to collect and carry oxygen. So failure to oxygenate results in mild to severe oxygen desaturation with profound cyanosis. Okay, these kids can present with saturations of O2 saturations as low as 50 to as high as 90. So we're having more cyanosis with this because we're not getting blood to the lungs. With the acyanotic lesions, what are we doing? We are getting some blood to the lungs. So that's the difference between the cyanotic and acyanotic. Decreased pulmonary blood flow. To compensate for the lower oxygen saturations, what is our body going to do? Our kidneys are going to produce erythropoietin to stimulate stimulate bone marrow to produce more red blood cells. Although we have a lot more red blood cells that are circulating in our body and carrying oxygen, that will not change the amount of blood reached to the lungs to collect oxygen because we have something that is causing that blood not to get to the lungs. So we have like an obstruction. Okay. We also have, because we have extra red blood cells floating around in our body, we have a higher hematocrit level, right? And so then we're going to have maybe a little bit of change in that oxygen saturation, because we can give a little bit of oxygen, but once again, it's not getting to the lungs. We're going to also have polycythemia because of that high hematocrit level. Okay, so we're going to have very thick, viscous blood that's not going to get where it needs to go because of that sluggish blood flow. So if there's any surgeries or traumas. So also with that sluggish blood flow, what is that going to lead to? Cerebral infarcts, so small clots, brain abscesses. Things can, because of trapping of bacteria. And then we can have pulmonary infarcts due to that sluggish blood flow. So one such defect that has this decreased pulmonary blood flow, that a cyanotic lesion that has decreased pulmonary blood flow, is tetralogy of Fallot. Tetralogy of Fallot occurs in about 5 to 7% of all kids with a congestive heart disease. And it is one of the most common types that results in cyanosis. It needs to have these 4 defects, 4 abnormalities to be tetralogy of Fallot. If it does not have a ventral septal defect, it does not have pulmonic stenosis, does not have an overriding aorta, or does not have a right ventricular hypertrophy, it is not tetralogy of Fallot. Okay? Some of these kids may not show signs of cyanosis at birth because it depends on the severity of that pulmonic stenosis and possibly that ventricular septal defect. But as they get older, or those periods of when their body needs more oxygenation, so when they're crying or they're feeding, we're going to have those episodes of that cyanosis, or TET spells, or cyanotic spells. Okay. So here's a picture of a normal heart and a picture of tetralogy of Fallot. Okay. So your book doesn't have the greatest picture of the overriding aortic or aorta, but it's better than the one that I have here. So you may want to pop open the book pictures as well. I want to say 666 in the separated book, and it is on page, where is it at? Tetralogy of Fallot. In the combined book, it is on page, I always lose this one when I'm looking for it. Tetralogy of Fallot is on page 1468. So in this picture, what color is going to be better? Let's try the black. In this picture, we have the ventral septal defect right here, because we have the opening. We have a narrowing right here in the pulmonic artery and that pulmonic valve. We have a hypertrophy, a large right ventricle. What you're not seeing is that overriding aorta. So the overriding aorta is kind of, the aorta comes down and around, and it kind of sits open to both the right and the left ventricle. So it's kind of opened up on both, so it's getting blood flow from both sides. So how is this kid going to present to us? It's quite interesting, actually. So they may be cyanotic at birth depending on the severity of those issues. But the cyanosis will progress over the first year of life as the pulmonary stenosis gets worse. They're going to have a systolic murmur, kind of moderate in intensity, and that's due to that blood flowing between the ventricles and then trying to get through that pulmonary stenosis. These kids are going to have those blue or TET spells when they are having anoxic spells would be another good word for it, when they're having increased oxygen requirements that are above what their blood supply is, because once again they're not getting oxygen to their lungs or blood to their lungs to get good oxygenation to the rest of their body. So therefore, when their body needs more oxygen, the body isn't able to compensate, and so they're cyanotic. So the precise mechanism of TET spells is a little in doubt. But we're thinking it's a result due to the transient increase in resistance to blood flow to the lungs, with increased preferential flow of desaturated blood to the body. TET spells are characterized by sudden, marked increase in cyanosis followed by syncope. And so we may have some hypoxic brain injury and death. So these kids, they're having this TET spell. And sometimes it will clear up on its own after the child stops crying. However, during that crying episode, we're not getting a lot of blood flow. So what we teach the parents to do is either put their knees to their chest, or as the kid is getting older and until they start to learn and grow out of some of these issues and their circulation gets better, these kids will start to squat. And what squatting is doing is closing off the blood flow to the lower extremities and keeping all that blood flow to the upper extremities, and allows for improved blood flow to the brain and the vital organs. And it can help stop with that pressure change and help decrease the side effects of the TET spell. So what do you think I'm going to teach these parents when these kids go home? Because they're not going to get all their repairs done right away. I'm going to teach them to put that kid in that squatting position to help whenever they have these spells. Okay, so relieving those hypocyanotic spells. Page 677 of the combined text. I'm trying to think not the combined text, the separated text. In the combined text, it is on page 1479. So we're going to be calm and comforting, because if I am anxious and stressed out, is that going to help the child? No, because that's going to just make it worse. Then I'm going to place that infant or child in that needed chest position that I just explained. I'm going to give them a little bit of supplemental oxygen. So parents, they're already going to be on oxygen. Or if the child isn't on oxygen, we usually give them some oxygen on the side in case the child needs it. So they may put them temporarily on a little oxygen. Granted, it's not going to change the issue much, because what's happening, we're not getting a lot of blood flow to the lungs. However, that little bit of extra oxygen is going to increase that percentage just a little bit. Us as nurses, we can give morphine or propranolol. However, I've never given the propranolol. I have given morphine. And then we're going to give IV fluids, because what are IV fluids going to do? Decrease that thick, viscous blood, and help with that blood circulation a little bit. Okay, so what do? These kids are going to need to have surgery. And sometimes it's a phased surgery. Sometimes they'll do all of it at once. And it's going to all depend on the severity of the kid's symptoms, on how soon they do the surgery. So if they're having tons of cyanosis, then we're going to do the surgery a little bit faster. If they're having more of those spells, we're going to do the surgery a little bit faster. Why are we holding off? The bigger the child, the stronger and the more chance of survival, or the less likelier side effects of surgery. We're going to close that VSD, and then we're going to resect that stenosis. Now, been hearing that we've been doing some stage surgeries. So they'll go in maybe and do this VSD closure by with that investigational type of repair, and then they'll see how the stenosis is going, or they'll go in and do the stenosis repair, because we can do that by cardiac cath, open that up, and then eventually we'll close the VSD. So it just kind of depends on the symptoms and the doctors and what we're all learning on how soon they do the repairs. But as we know with some of these, the best way to do it is to cut that chest open and get in there. So cardiopulmonary bypass. We could still have congestive heart failure after surgery because of all that fluid backing up and things, but long-term effects with these kids can sometimes be better than the outcomes of not changing or not doing anything at all. These kids do get sent home before they're having repairs. They will sometimes be home on meds for the side effects, and the parents will get follow-up appointments and do really well. They will go home on monitors, and they usually go home with some oxygen. The parents are taught what to do, and they, with proper following, they do fairly well. Okay, the last type of defect, a cyanotic defect that can cause mixed blood flow, we're going to talk about is hypoplastic left heart syndrome. These are mixed lesions that are present at a variable clinical picture based on the degree. So depending on what the issue is. We have an inability of the blood to reach the body. So we have symptoms of low cardiac output are noted. These kids may have diminished pulses, poor color. Capillary refilling time is really bad. They have decreased urine output. Those signs of diminished blood supply to the GI tract, so neck, retizing enterocolitis, GI tract issues. Blood cannot move past the obstruction, so what does it do? It backs up into the left atrium and then into the lungs. So then we're going to have CHF issues with pulmonary edema. It all depends on the extent of the obstruction and the symptoms. So depending on which ones of these disorders we're going to talk about. We're going to do hypoplastic left heart syndrome, and this is pretty severe. Also, some things that we're going to see with some of these defects is the left ventricle will attempt to overcome the diminished blood flow produced by the obstruction, and it's going to get bigger and bigger and bigger. So it's going to be very thick. That muscle will eventually wear out and weaken to the point of left ventricular heart failure and then poor cardiac output. Okay, so with hypoplastic left heart syndrome, we have an underdevelopment of the left side of the heart, so that left ventricle usually. And it results in the hypoplastic left ventricle and aortic atresia. The left side of the heart is unable to send blood to the body. So as a result, the right side of the body must maintain the circulation for both the lungs and the body. This extra workload eventually causes that heart to fail. These kids, when they're born, they're going to be mildly cyanotic, and they're going to have signs of congestive heart failure until that ductus arteriosus closes. And then progressively deterioration is going to occur with that cyanosis and decreased cardiac output. Then we're going to have cardiovascular collapse. These kids will die within months of their life without intervention. Because if you think about it, what is that the ductus arteriosus doing? It's allowing for that mixed blood flow. So if that closes off and they don't have any connection of the right side to the left side of the body. So here's a nice, beautiful picture of hypoplastic left heart syndrome. So that only possibility of survival for these kids is that connection between the right side and the left side of the heart, is the blood vessels through which the blood may pass. So we have that natural shunt in those infants when they're born, which were the foramen ovale and the ductus arteriosus. That's what those were doing when they were born, right? So if those close, we don't have those shunts. So these kids need to have one of those shunts left open. And the only one that we can keep open is that ductus arteriosus. So if the ductus arteriosus is allowed to close in a baby with hypoplastic left heart syndrome, that's when we will get that death. Okay. The patent ductus arteriosus is closes with prostaglandins. Is when we prostaglandin inhibitors. So the prostaglandin infusion is needed to maintain ductal patency. So we're going to give this kid prostaglandins because the prostaglandins is going to open it. Now in a kiddo that has a PDA that we're wanting to close, we're going to give them prostaglandin inhibitors. So this kid, we're going to keep it open, so we want to give them prostaglandins. However, we can't give them prostaglandins for days, months, weeks, years. So they're going to get them until we can get them ready for surgery. Okay? So it might be a few days, few hours type of thing. Okay. So multi-stage approach. The first surgery is going to be done within hours to the first day of life. It's the Norwood operation. After the Norwood, that baby can then go home, and they'll take more medications to kind of keep them perfusing, keep them healthy, make sure the pressures are staying low. Pediatric cardiologist is going to follow up, and then eventually we will determine the second stage of the surgery. These kids are going to be cyanotic forever until all their repairs are done. So this kid, we are not going to teach these parents to call me if there's worsening cyanosis or if I'm seeing cyanosis, because this kid's baseline is going to be cyanosis until all their surgeries are done. So the Norwood is going to build a new aorta and get that shunt going so that we can have flow to both the right and the left sides of the body and get that blood flow to the lungs and back into the body. Okay. Stage 2 is going to be done typically around 4 to 6 months, but again, this could change depending on the surgery and the doctor and the baby. This is called the Glenn shunt or the hemifontan. This procedure connects half of the veins carrying the blue blood from the body, so the deoxygenated blood from the body, so the superior vena cava, directly to the blood vessels of the lungs so we can get that oxygen going. Like I said, this is sometimes done around 4 to 6 months of age. So the third stage of the surgery is the Fontan procedure. This is when the remainder of the veins carrying deoxygenated blood from the body, the inferior vena cava, is connected directly to the blood vessels of the lungs, and the right ventricle now serves as the only pumping chamber for the heart. This surgery is usually performed between 18 months and 3 years of age, and this is the final step. And after this is done, the child is considered no longer cyanotic. They're going to always have mixed blood flow, but at least their underlying symptoms are no longer going to be cyanosis. So many of us are probably thinking, well, why not just do a heart transplant? Well, yeah, sometimes we do it, but there are very few donated hearts that are small enough for infants. We can't put an adult heart in an infant, so the only way to get heart transplants for these kids is to have another child die, or infant die. So we do the surgeries to get the baby to that stage, and some people may only do the first surgery and get that kid on a transplanted list. This kid may get a heart transplant later in life after all these surgeries, because what's better for them? To have a normal functioning heart. But we need to allow them to have some sort of life. So we're going to do some of these surgeries. We may get through all 3 of them before they're able to get a transplant. They may need more surgeries later in life because arrhythmias could occur because of the fontan and how everything is developed and making the heart flow. You can have failures, things like that. So that's why these kids may end up with heart transplants later on as well. Remember, if left untreated, hypoplastic left heart syndrome is fatal. So once we do that first repair, we go from complete fatality to a 75% survival rate. And then that goes up as we do each surgery. So we need to do something. All right. So, congenital heart disease management. Besides doing all of our surgeries and different things, we'll be doing arterial blood gases, chest x-rays, MRIs, ECGs, EKGs, blood studies, just to kind of see what's going on, how that heart's pumping, seeing what complications we're having. And then we can do preventative prenatal care beforehand to help decrease the long-term effects or the severity of the issues. These kids that have some of these issues, they may not be able to get pregnant because it's going to increase their complications in pregnancy and the demands on their heart. We're going to do continuous monitoring of their cardiac and respiratory status. So a kid that just has a minor infection, I may not look at their heart rate and their respiratory rate as frequently as I am with these kids. Making sure I'm giving those medications as needed and as ordered, and teaching our parents the importance of these things. And then that follow-up with the family of the importance of taking their meds, why they need to take it when it is, those signs and symptoms of side effects, when to call for issues, complications, things like that.